And so, and the first thing you do in the abdominal exam is I'm going to be inspecting, and I'm inspecting the contour, pigmentation, looking at the texture, any visible vessels, any peristalsis, any pulsations, any scars, any tattoos, and there appears to be none. And now I'm going to auscultate the abdomen. So, and I told you it may say the diaphragm or the bell in any of this, but it doesn't make a big difference. We're going to first auscultate in all of the 4 quadrants for tympany. So, okay. Vowel sounds are present in all 4 quadrants. Tympany would be with percussion, not with auscultation, right? I screwed that up. Okay. Next, we're going to auscultate the abdominal vessels. So I'm going to auscultate the aorta, renal, iliac, and then the femoral, and I'm going to put my stethoscope in your groin area, okay? All right. So you just pull this up a little bit, get down there where it's supposed to be. Sorry. And there's no bruise noted. The next we're going to go to percussion of the abdomen, and first we'll percuss in all 4 quadrants for tympany, right? So. Okay, percussion's tympanic in all 4 quadrants. And now we're going to try to percuss the liver size, starting in the midclavicular line in an area below the umbilicus and percussing up. Okay, a little bit of a change in sound there, so we've marked that, and you really will mark it when you do it, okay? I wouldn't recommend it so much when you're practicing or you'll be marked all up, but on the real exam you have to mark it, okay? So once we've marked that, we'll start percussing up here in an area that we're pretty positive is resonant. Okay, it's a sound change there, and you'll mark that, take your ruler out, measure that, and it appears that the liver is about 6 centimeters in the midclavicular line, okay? Next, we're going to percuss the spleen. So, I'm going to put the finger in the lowest interspace, anterior axillary line, and percuss once. Okay, take a deep breath in. And spleen remains tympanic, so that means that the spleen was not enlarged so far as we could tell just by percussion. Okay, so the next thing that we're going to do is we're going to begin palpation, all right? Palpation first, light palpation with one hand in all 4 quadrants. So, feel any discomfort there? No? Okay. Now we're going to go with deep palpation, and then again in all 4 quadrants. Epigastric area, umbilical area, and suprapubic area. Any of that bother you at all? Okay, so there was no rebound, no guarding, no rigidity, no tenderness to deep palpation. Well, I didn't check for rebound, but there wasn't any, right? Okay. Next, we're going to palpate the abdominal aorta. So we're going to try to go in a little bit left of the midline in the upper abdomen here and try to detect pulsations. I figured I could get them on him where you can see it, but he's pretty thin. Well, it appears the aorta is 2.5 centimeters in size, and there's no lateral expansion of pulsations. Okay, so now we're going to palpate the liver, and I'm going to take my hand, put it under the rib cage here, and go in the area that's just below where I marked on percussion, and have you take a deep breath in. Okay, the liver edge is smooth and non-tender, and now we're going to palpate the spleen. So I'm going to come across here and go ahead and lift up like this, and where the spleen was, take a deep breath in. Okay, spleen is non-palpable, and we're going to come over here and do the left kidney. So we're going to put our hand in the costovertebral area, lift up some, and ask him to take a deep breath in again. Okay, the left kidney is non-palpable. I'm going to come over here to the right side, and again, take a deep breath in. Okay, the right kidney is non-palpable. And then the next thing that we could do is, is go ahead and palpate for the femoral pulses, all right, on both sides, and then also feel for adenopathy in the vertical and the horizontal chain of lymph nodes on both sides there. But I just don't want to, do that again to him. And we don't have any drapes or anything. He's just got pants on, but you get the gist of it, right? So we would do that, and then the next thing we could do is have him go ahead and sit up. Let me sit up. Yeah, and then we're going to do that. Bring your legs right here so she can get it on film. And then we're going to do the percussion for CVA tenderness. So hand goes over like this, and does that hurt?
No.
No? Okay. Same thing again. Didn't hurt. Go ahead and lay that down. Now, that was the best I can remember of the regular part of the exam, and now we're going to talk about, I'm going to show you the special exams. Okay, so first we're going to check for any kind of peritoneal signs, and we would have saw some of that when we did the exam if he were tender or if he were guarding, and there was none of that. But now I'm going to have you, can you cough? Does that hurt your abdomen anywhere
No.
at all? Okay. And then we would take the heel and jar him like that, and you can see how that jars the abdomen. Does that hurt your belly at all? No. Okay, good. And then after we check that, we can also check for rebound tenderness, and so you would do it just like you're palpating for tenderness, except you can let go. Does that hurt when I push in? Does it hurt when I let go at all? Okay, none more than the other. So there's no tenderness and there's no rebound tenderness, okay? If I press in over here, does that hurt over here?
No.
Okay, so there's also no referred rebound, and the Rossving sign is negative because he didn't have pain in his right lower quadrant when I deep palpated in the left. So the next thing we could do is a psoas sign, and with this one, I'm going to, somebody blowing up my phone over here now. So put my hand right above the knee and have him raise his leg up to kind of engage that musculature. Does that hurt?
No.
No. Okay. So the psoas sign is negative, and now we're going to do obturator. So bring this up, this knee up, flex it to right here, and then internally rotate. Anything there? Okay. So the obturator sign is also negative. You can palpate, make sure we've already palpated in the right lower quadrant, but mention McBurney's point, and he's not tender there. Just another thing to look for when looking for appendicitis. Now, for acute cholecystitis, we can do what we call Murphy's sign. You again place your hand under the lower rib cage on the right-hand side, a little bit medial to where we went before. Tell him to take a deep breath in, then go up, and if he were to have a sudden inspiration and a sudden cessation of his inspiration, or a grimace or an increase in pain, that might be a positive Murphy sign, which could indicate acute cholecystitis. All right. So we've got that one, and other special exams. We're going to check for ascites. First, he doesn't have bulging flanks, but if he did, we could determine if it was fluid or not by beginning to percuss out from tympany to dullness, and then do this like was on the picture in several areas to see if you get the fluid, and then kind of remember where that's at. We don't need to make a big mark all the way around somebody, and then have him roll up on his left side. It's better if you can put your arm up like this, your left arm. Yeah, and then you can roll over better. Yeah. Okay. And then now we'll start to percuss down from tympany. There's not going to be a change on him because he doesn't have ascites, okay? But that's what you would do. That's how you would check for it. Okay, roll back down. Okay, now the fluid wave, it would be the other one we could do. And would you mind taking your hands and put them together like this and then press really hard down the midline of your abdomen? Are you able to do that? And then I'd take this hand, I'll do it from this side since you're over there, but and put it here, and then and you can see how the transmission from the fat gets stopped right there. It doesn't jiggle on that side, just this side. But there's no vibration that gets to this hand, so there's no fluid, and really there's no fat. You don't have fat, right? And the next thing we could look for would be hernias, midline hernias, or the diastasis recti that I explained. And by that you could feel the midline, make sure there's no hernia, not too much of a separation, and then you can try to lift your shoulders up off the table. Yeah, and so that tightens his muscles up, and there's nothing there either. And then also part of a good abdominal exam when you suspect pathology would be to do a pelvic exam and do a rectal exam too. Okay, and I think that's it.